Hi, welcome to the ground round. This is the first ground round in 2022. Thanks to Omicron, I guess we are back to virtual ground round. We're so excited to have this wonderful speaker. But before having the speaker announced, we'd like to get everybody's attention for getting a CME credit for today's ground round lecture. Call this number 801-478-5852 and enter 018230. So please get a credit. You can do this by the end of today. And with that, I'd like to introduce Megan Mill, Dr. Megan Mill, the Section Chief of Musculoskeletal Radiology and a Co-Director for Residency Program, to introduce today's guest speaker. Thank you.
Thanks, Yoshimi. So we're thrilled to have Dr. Caitlin Connolly with us today. Dr. Connolly is an invited speaker participating in the AUR Career Advancement Leadership Program. And Dr. Connolly attended medical school at the University of Massachusetts, did residency training at Beth Israel Deaconess in Boston, and she did fellowship training at the Harvard Joint Program in Nuclear Medicine. She is currently the director of Nuc Med at Mount Auburn Hospital, and she has clinical interest in oncologic infection and inflammation imaging. And she also serves as the institutional RSO and as the APD for diagnostic radiology. So please help me in welcoming Dr. Caitlin Connolly.
Thank you so much for that kind introduction, Dr. Mills. Share my screen. Good afternoon, everybody. Thank you so much to the AUR, APDR for putting together the Radiology Career Advancement Program. And thank you to you at the University of Utah for participating and inviting me. I really appreciate the opportunity. Today, I'm going to talk about nuclear medicine imaging of infection and inflammation. And just to give you a sense of where I'm from, this is Mount Auburn, which is located in Cambridge, just across the river from Boston. This is a nice image in spring when it was a bit warmer. This is one I took this morning looking out from our department towards Boston across the river, a little bit chillier, although all the snow had melted from last week, which was nice. I have no disclosures. And just to give you a bit of background on infection and inflammation. So infection remains a leading cause of mortality and morbidity, both globally and in the US. This is data from the WHO. The latest data they have available on their website is from 2019. But you can see that lower respiratory infections were the fourth leading cause of death globally, and diarrheal diseases were number 8. And as you know, we're in the middle of a pandemic. For the US, the CDC has data on their website from 2020, and COVID was the third leading cause of death. And then pneumonia was number 9 for the United States. And early diagnosis and pathogen identification is becoming even more critical as antibiotic resistance rises. There was a white paper that was commissioned by the British government in 2016 that estimated that antibiotic resistant infections will be the leading cause of death globally by 2050. So becoming an even bigger problem as time goes on. The gold standard of diagnosis of infections has been sampling and culture allows identification of specific organisms and antibiotic sensitivities. But it can be challenging to get samples, especially in deep-seated infections or areas that are sensitive for getting samples. And some organisms are difficult to culture depending on their growth rates and things like that. Imaging plays a key role in diagnosis and follow-up, as I'm sure you all know. And historically, nuclear medicine was the primary imaging modality for imaging infection. This is a gallium-67 scan with PCP pneumonia in a patient with AIDS from quite a while ago. But now it's largely been replaced by CT and MRI as the initial diagnostic test of choice. However, nuclear medicine still has diagnostic utility in specific clinical scenarios. And so today we'll talk about the different radiopharmaceuticals that are used for imaging infection and inflammation, and discuss specific clinical scenarios where nuclear medicine may be helpful for problem solving. And I would say that one of the more common questions I get from my diagnostic radiology colleagues and also ordering physicians is there a nuclear medicine test that could be helpful in a specific clinical situation, whether it be fever of unknown origin or osteomyelitis, or maybe they have contraindications to MR. And then if so, what test should I order? So we'll try to cover those questions today. And then we'll briefly talk about emerging radiopharmaceuticals for imaging infection. There's an active area of research on new radiopharmaceuticals we'll cover. So radiopharmaceuticals that are commercially available include technetium-99m methylene diphosphonate, or MDP, bone scanning, indium-111 or technetium-99m labeled white blood cell scan, which is also called a tagged WBC scan. Gallium-67 citrate is no longer really widely used, so we'll only briefly touch on that. And then F18 fluorodeoxyglucose, or FDG PET CT. So coming to the clinical questions, the first question I often get is, can you help with diagnosis of osteomyelitis? Is there a nuclear medicine scan that can help? So as you know, when you're working up suspected osteomyelitis, the first test of choice is going to be a plain film. And then if they can get an MRI, typically the patient will go on to MRI. If they can't get an MRI, either they have maybe an implanted device that's not MR compatible or claustrophobia or something along those lines, you could consider doing a bone scan or a tagged white blood cell scan. And so we'll discuss when you might do one or the other. So to figure that out, you want to go back to the plain film. And if the patient has undisturbed bone, meaning they have not had prior trauma or surgery, they don't have a Charcot arthropathy or other inflammatory arthropathy, then bone scan would be your test of choice. So we'll talk about bone scan first. So technetium-99m MDP bone scan, you inject your MDP intravenously. It's a phosphate analog that is carried relative to blood flow and then absorbed into the hydroxyapatite matrix by osteoblasts. So if you have increased blood flow or increased osteoblastic activity, that will increase your uptake. And then you're going to image your area of interest wherever you're suspicious for osteomyelitis, and you do immediate blood flow images typically, followed by blood pool images right after your blood flow images, which will show you the soft tissue uptake, and then delayed skeletal phase images at 3 to 4 hours and whole body images. And then you'll typically also do a SPECT CT of the area of interest. You can also optionally do a fourth time point at 18 to 24 hours, depending on your department protocol. So 3-phase bone scan can distinguish between osteomyelitis and cellulitis with high sensitivity and specificity when plain radiographs are normal. And the ACR appropriateness criteria, as I'm sure most of you are familiar with, is a set of criteria that the American College of Radiology came out with to talk about which tests might be appropriate in specific clinical situations. And it's broken down into usually appropriate, which they give, there's a 1 to 9 point scale. So 7, 8, 9 is usually appropriate, maybe appropriate is 4, 5, 6, and then usually not appropriate is 1, 2, or 3. So they say maybe appropriate depending on the clinical scenario. And we'll talk about the findings in cellulitis, osteomyelitis, and septic arthritis. So here's a case of a 52-year-old woman with diabetes, and she has right heel ulceration and left foot swelling and redness and was unable to get an MR. And so here are our initial blood flow images on the left here. And you see this is the right heel. We see increased blood flow in the region of the right heel. And in the left foot, we see increased blood flow to the whole plantar aspect of the midfoot here. Then we do our blood pool images looking at soft tissue uptake, and we see increased soft tissue uptake in the region of the right heel and also the plantar surface of the left foot. And then on the delayed images, we see focal increased uptake along the inferior posterior aspect of the calcaneus here. That's the region of her ulceration. And on the left foot, we don't see any focal uptake in the bones of the foot. And so this is consistent with osteomyelitis on the right at the calcaneus and cellulitis on the left. And so the key findings of cellulitis on bone scan are going to be increased activity on the angiographic phase, increased soft tissue uptake on the blood pool phase, but no focal uptake on the skeletal phase, only mildly increased osseous uptake, which is due to the increased blood flow. Here's a companion case of right foot pain with swelling and redness. And you see in the blood flow images here on the left, increased blood flow. This is an AP view, so this is the right foot. And we're seeing on the lateral aspect of the midfoot of the here, increased blood flow. And we also see increased soft tissue uptake here, again, in the midfoot on the lateral aspect. And then on our skeletal phase, we see focal uptake here in the lateral aspect of the midfoot. And you would want to do either a SPECT CT or probably lateral views to confirm, but this was in the 5th metatarsal. Here on the left foot, we see focal uptake not as intense in the midfoot without any correlate on blood flow and blood pool. And this is degenerative change in the midfoot, and you can confirm that with plain films. So key findings of osteomyelitis on bone scan are increased tracer uptake on all 3 phases of the 3-phase bone scan, with focal intense uptake on the skeletal phase at the site of osteomyelitis. We don't typically do bone scan for septic arthritis. Usually if you're suspecting septic arthritis, you would tap the joint to get a sample. But if you did bone scan, you would see increased uptake on both sides of the joint for septic arthritis. All right, so if the patient you have suspicion for osteomyelitis and they cannot get an MRI, but their bone has been previously disturbed either by trauma or surgery, then you want to go to tagged white blood cell scan. And the reason for that is that bone scan is very sensitive, but it's not going to be specific. If you've had prior trauma or surgery, that would also cause increased uptake. So in that case, you want to go to tagged white blood cell scan. And so when you're doing a tagged white blood cell scan, you are labeling the patient's own white blood cells. And there's typically a mixed population of circulating white blood cells, the majority of which are neutrophils, with a minority of lymphocytes and then other cells such as basophils, monocytes, and eosinophils. And due to that neutrophil predominance, when you're labeling white blood cells scan, when you're doing a labeled white blood cell scan, it's going to be most sensitive for acute bacterial infections, which elicit that neutrophil response, as opposed to parasitic or viral infections, which is not going to be as sensitive for. It's very important to have blood product handling safeguards in place because you are going to be drawing blood from the patient, labeling it, and then re-injecting it. And you need to prevent re-injection into the wrong patient. So multiple forms of a patient identification, making sure your vials are correctly labeled. We usually have the technologist who drew the blood be the same one to re-inject it if at all possible. But that's very important. And you need about 50 cc's of blood to centrifuge, and you isolate the white blood cells, and you label with either indium-111 oxine or technetium-99m HMPAO, and we'll discuss in a minute why you might choose one or the other. Both are lipophilic radiotracers that cross the cell membrane. You then re-inject the white cells via IV and then go on to imaging. In order to do a tagged white blood cell scan, you need to have at least 2,000 cells per ml to label. So you're not going to be able to do a scan in a patient who is severely neutropenic. And so the differences between indium and technetium-99m labeled white blood cells are in part based on the half-life of the agent. So indium-111 has a 67-hour half-life, and technetium-99m has a 6-hour half-life. And so because of the longer half-life, you can image later after injection with indium. So you typically image around 24 hours post-injection. And the initial biodistribution will be in the lungs, blood pool, liver, and spleen. And then it will clear from the lungs and blood pool, and you'll get most intense in the spleen, followed by liver, and then bone marrow. In technetium-99m, because of the shorter half-life, you image sooner. So you image at 3 to 4 hours post-injection. And you have similar initial blood pool, but then after about 3 hours, you'll get excretion, excuse me, of the unbound technetium-99m HMPAO into the GI tract, gallbladder, and GU tract. And you can see here there's a little bit in the bladder. We don't have much in the way of GI tract here, but that can be a pitfall for abdominal infection because you have sort of physiologic uptake, and it can be challenging to know whether it's because of infection or just physiologic excretion. And so here's an example of an indium-111 scan on the left and a technetium-99m scan on the right. And you can see that the indium scan has less soft tissue background than the technetium scan, and we don't have the bladder. It also is a little bit noisier. You can't inject quite as much activity because of the long half-life. The dose sticks around radiating the patient for longer, so you have higher radiation doses to the patient, and consequently can't inject as much activity. So you can do higher doses and you get better count statistics with technetium. So in terms of sort of pros and cons of both of them, I briefly mentioned, but the delayed images allows for clearance of background activity on indium, and you can do simultaneous dual isotope imaging, which we'll cover in a little bit, but imaging with both indium-111 white blood cells and technetium-99m labeled sulfur colloid for bone marrow scans, for example. The downside is it takes a long time. So you are imaging a day later after injection. It also, indium is not usually commercially available every day of the week. So depending when you're ordering, it's usually not available on weekends. It may take a few days to get a dose and then you have to wait another day. So that's suboptimal for, these patients are usually sick when you're looking for an infection. And then the poor count statistics for SPECT, as I mentioned. Technetium-99m, you can inject higher activities. You have better resolution and you have shorter delay in imaging, but there is less time for the white blood cells to accumulate at site of infection, and then higher background activity and also the GI and GU activity. So when might you do a labeled white blood cell scan? We talked about osteomyelitis. So if the patient has had prior trauma or surgery, for example, a tagged white blood cell scan may be helpful. And it's typically done in conjunction with a technetium-99m sulfur colloid bone marrow scan if you're imaging in an area that would have normal red marrow. So for example, the hip or proximal humerus, the white cells go to hematopoietic marrow. And so in order to differentiate whether the cells are collecting there because of infection versus just normal physiologic marrow, you need to kind of map where the marrow is. So infection would have a greater uptake than on white blood cell scan than on bone marrow scan. And the ACR appropriateness criteria for a labeled white blood cell scan in this scenario is, again, may be appropriate, so depending on the clinical scenario. So here's a case of a 37-year-old woman who had a history of a motor vehicle accident and had, excuse me, right tibia and fibula fractures, status post intramedullary rod placement 2 years ago, and comes in now with pain and fever. And you can see this is an indium-111 white blood cell scan at 24 hours after injection. And just to orient you, these are anterior view of the lower extremity. So the knee is sort of up at this level, the right and the left. Ankles are going to be here. And then this is tibia and fibula. And we see on the right, there's uptake in the proximal tibia as well as mid tibia, and then this rounded area of uptake. And you would need another view to know, is it within the tibia or external, but it is within the soft tissues and also within the region of the tibia on the right here. On the left, we see uptake in the proximal tibia extending sort of to the mid to distal tibia. So the question is, this certainly looks suspicious for a collection. It's a collection of white blood cells. It's likely a soft tissue abscess. And then the question is there osteomyelitis, and how far up the tibia does it go? And so the way to tell that is to compare with a sulfur colloid scan. And so this is going to map where the normal bone marrow is. And so we see in the proximal tibia and mid tibia on the right here, there is normal marrow that is congruent with the white blood cells we saw here. But in this area, we have no normal marrow. So this is osteomyelitis of this distal tibia with a soft tissue abscess. And then on the left, we have normal marrow, and you can see it matches, so it's congruent on both. So this is osteomyelitis with a soft tissue infection. And after they took out the hardware, you can see the follow-up radiograph, the osteolysis of that tibia with, where they've debrided from the soft tissue infection. So key findings of osteomyelitis on a tagged white blood cell scan are going to be greater uptake on the white blood cell scan than the bone marrow scan. either in intensity or spatial non-congruence. So this was sort of the spatial non-congruence here. If you're in an area that doesn't really have a lot of red marrow, you might be able to get away without the bone marrow scan. So it depends where you're imaging. If you're imaging, fingers or toes, there's not usually a lot of red marrow. So you could do potentially just the white blood cell scan. So another indication for a labeled white blood cell scan would be to differentiate in the setting of a prosthetic joint, whether you have aseptic loosening or infected hardware when you have lucency around a joint on plain film. And reported sensitivity is high with slightly lower specificity. And again, the ACR appropriateness criteria for this is maybe appropriate. So again, depending on the clinical scenario. So here's an example of a 67-year-old man who has left hip pain 5 years after his left hip replacement. And at the tip of the hip here, there was concern for developing lucency. It's probably not projecting too well on a normal monitor, but that was the concern on the diagnostic monitor. And so the question is that from aseptic loosening or is it infected? And so here is our indium 111 white blood cell scan of the pelvis. And we can see here's the right proximal femur here, and the left would be here. It's relatively photopenic because there is a hip prosthesis in place, but we do see a couple areas of white blood cell accumulation. And again, the question becomes, is that normal marrow or is that abnormal accumulation from infection? And especially in the setting of uncemented hips, when they kind of put those in, it often will kind of pack the marrow down near the tip. So you can actually have increased uptake near the tip from normal marrow. And so again, we do the sulfur colloid scan, and you can see here that there's actually more uptake on the sulfur colloid scan than the white blood cell scan. And so this is consistent with aseptic loosening rather than infection. So key findings of hardware infection on a tagged white blood cell scan is greater uptake on the white blood cell scan than the bone marrow scan, sort of same as we talked about for osteomyelitis. If it's matched, then that would be more consistent with aseptic loosening. A labeled white blood cell scan is also helpful for diabetic foot infections to differentiate cellulitis from osteomyelitis. Sort of variable sensitivity and specificity in the literature, ranging from 70 to 100%. And again, the ACR appropriateness criteria says it may be appropriate. So that's kind of the question of osteomyelitis. Changing gears a little bit, the next question I often get asked is about fever of unknown origin. Is there a nuclear medicine test that can be helpful? And so, as I'm sure you're aware, the first line workup for fever of unknown origin is going to be a clinical workup, lab work, history, and then often plain films or cross-sectional imaging. But if all of that is not doesn't illuminate the site of or cause of the fever, then you could move to a nuclear medicine study. And sort of the branch point is going to be, is the patient neutropenic? If they're not neutropenic, then you could do a tagged white blood cell scan or FDG PET CT, which we'll cover later. If they are, you could do, again, FDG PET CT or gallium scan, which again, we'll cover in a little bit. But for the tagged white blood cell scan, it's quite useful in fever of unknown origin in that it gives you whole body imaging. So, if they have a extremity infection or something like that, that maybe wouldn't be covered in your typical torso CT, you would pick that up. The sensitivity is about 90% for acute infection, a little bit lower for chronic infection. And fever of unknown origin is typically caused by sort of 3 categories of etiology. So infection is one of them, but neoplasm can cause about 1/3, and then inflammatory processes can cause about 1/3. And so it's not so useful in the neoplasm or non-pyogenic infection or inflammation. So one cause of fever of unknown origin is vascular infections. If they've had a vascular graft, those can become infected and can be challenging to diagnose on cross-sectional imaging. So you can do a tagged white blood cell scan, and that has a sensitivity of about 90%, but variable specificity in the literature, and causes of false positives, anything that's going to cause sort of accumulations of blood or lymphocytes, hematomas, a thrombosed graft, bleeding or pseudoaneurysms. And then in the setting of recently placed grafts, there may be some inflammation that can be a cause of a false positive. It's also useful for detecting mycotic aneurysms and assessing implanted device infections, which are another cause of fever of unknown origin. So here's an example of a 75-year-old man with fever of unknown origin. And he had an indium 111 tagged white blood cell scan. This is a frontal view, and you see most intense uptake in the spleen, followed by liver and bone marrow, which is normal biodistribution. And then he has this linear uptake in the medial right thigh. And he has a history of a right femoral popliteal bypass graft, and this is an infected bypass graft. Here's a companion case of an 85-year-old with bacteremia of unclear origin. And he had a non-contrast CT. This is an axial view through the abdomen. I think he had renal function issues and maybe a contrast allergy, so couldn't get IV contrast. And we see here at the level of the abdominal aorta, this is sort of his normal aorta, and then he has an aneurysm here along the right side with focal outpouching. And here we see on the coronal view this focal aneurysm of his aorta with interruption of the vascular calcifications. And when he had a tagged white blood cell scan, he had focal uptake corresponding to that aneurysm, and that was a mycotic aneurysm. The limitations of white blood cells is a lack of specificity, and you'll hear this is a limitation of most of these radiopharmaceuticals. So inflammatory processes that can trigger the immune response also are positive on white blood cell scans. So a classic example of that is inflammatory bowel disease will be positive. And there's also a lack of sensitivity for spinal osteomyelitis. You often will see a photopenic defect rather than increased white blood cells, and we'll talk more about that in a bit. This was an example of a 47-year-old woman with inflammatory bowel disease who comes in with a fever, and she had a technetium-99m labeled white blood cell scan. And we see again spleen, most intense, liver, and then marrow, and then uptake in the pelvis. And if you remember, I told you you have normal excretion into the GI and GU tract. So is this physiologic or is it infection? It's challenging to know. So we did a SPECT CT. And you can see here is our images of the white blood cells. Here's the CT, and this is the fused image. And there's uptake in the bowel, which corresponds to her inflammatory bowel disease. And then she has this presacral collection here with fluid and air, which has white blood cell accumulation. And this was a Crohn's flare with fistula formation and a presacral abscess. So it's sort of a mix of both inflammatory and infectious causes of white blood cell uptake. So that's fever of unknown origin. Another sort of special situation is spinal osteomyelitis. And I get asked not infrequently, patient can't get an MR for some reason. Is there an option in nuclear medicine to help with spinal osteomyelitis? And the first line, if you can get it covered, is FDG PET CT. And the difficulty is that the Center for Medicare and Medicaid Services, or CMS, previously had it listed on sort of a non-covered list, basically for all infection osteomyelitis, fever of unknown origin. But as of a year ago, so January 2021, they took it off the non-covered list, and now it's decisions are made by local Medicare administrators. We, at least here, are still not having any success getting it covered, but maybe, I don't know if you have had more success getting this covered. It's an expensive test, so cost is typically prohibitive if you can't get it covered. But that would be the first line. If you cannot get it covered, another option would be gallium-67 with a bone scan, which I'm gonna briefly cover just for we'll talk about gallium for historical purposes as well. So gallium accumulates at site of infection and inflammation, as well as some neoplastic tissue. It's an iron analog that dissociates from the citrate and travels bound to transferrin in plasma. And at site of bacterial infection, where you have degranulating white blood cells, it will preferentially bind to lactoferrin and bacterial siderophores. And the half-life of gallium-67 is 78.3 hours, so on the order of 3 days. And so you image typically at the 2 to 3 day range, and you will see at 48 hours, typically soft tissue, bone, liver, nasopharynx, and then variable activity in the lacrimal and salivary glands and breast tissue. And in the first 24 hours, there can be some renal excretion, and after 24 hours, it's typically GI excretion. So here's an example of a gallium scan where you see liver and bowel, and we see soft tissue, bone, nasopharynx, a little bit of lacrimal and salivary glands. So for vertebral osteomyelitis, if the patient cannot get an MR and you don't have FDG PET-CT as an option, then gallium-67 would be preferred over white blood cells. And the reported sensitivity and specificity is over 90% and is done in conjunction with an MDP bone scan. And a positive scan would have more uptake on the gallium scan than the bone scan. So here's an example of a 45-year-old woman with lower back pain and fever who had a contraindication to MR. And we see this is a posterior image from her gallium scan, and here's her lower back here. So at the level of L3, she has increased uptake on the gallium scan, and you can see it's more on the gallium scan than on the bone scan. So this was consistent with a vertebral osteomyelitis. Gallium, in theory, is also useful in immunocompromised patients. It's not dependent on the white blood cells, so it can be used in neutropenic patients. Historically, it was used for detecting opportunistic infections, especially in patients with HIV and AIDS, and differentiating between infection, Kaposi sarcoma, and lymphoma. The downside is it's not specific for infection. There's uptake in inflammatory conditions. For example, sarcoid will have gallium added, lymphadenopathy, and pulmonary uptake, which can mimic PCP or TB infections if you're trying to image infection. It's high radiation dose, long delay in imaging, and low resolution. So for all those reasons, it's not much used anymore. So let's talk about FDG PET-CT, which would be your first line if they couldn't get an MR. So F18 FDG is transported into cells via glucose transporters, the GLUT1 transporter, and phosphorylated by hexokinase, but then not metabolized. So typically will stay in the cell. And the cellular uptake is related to the metabolic rate and number of glucose transporters. And there's increased expression of glucose transporters by activated inflammatory cells. And so your typical biodistribution, as I'm sure most of you are aware, for FDG, anywhere that is using glucose for metabolism. So the brain is an obligate glucose user. The heart is variable depending on their fasting state. Red marrow, liver, it's excreted by the kidneys into the urines, and you see intense uptake in the urinary system. So here we see brain, some uptake in the left ventricle, kidneys, and bladder. And as I mentioned, up until recently, infection has not been a reimbursable indication under CMS rules, and most of the private insurance companies have followed the CMS rules, at least around here. So we've not had good luck getting it covered, but that may be changing. So for spinal osteomyelitis, this was a study out of the Netherlands in 2018 that had 32 patients, but they were comparing MR and FDG PET-CT and found them both to be basically 100% sensitive. The specificity was a little bit lower for FDG PET-CT compared to MRI, but both had very high negative predictive values. And for the PET, it was able to detect other sites of infection. You're doing typically either whole body or at least the whole torso imaging with FDG PET. So in these patients who are often bacteremic, you can see other sites of metastatic infection. MRI was more sensitive for epidural or spinal abscesses. It has better spatial resolution, and the soft tissue contrast is better for MR. So when they were looking at diagnostic criteria, basically looking for increased FDG uptake in the disc, and then also the adjacent end plates, which would give you a discitis osteomyelitis picture. If it's just in the disc, then it would be discitis. If it's just in the vertebral bodies, that's osteomyelitis, but that's a less common pattern. So that was sort of their grading and similar to the MR diagnostic criteria that we use. So here's an example of a 70-year-old woman with fever, bacteremia, and back pain. And this is an example from the literature where she actually had a negative MR initially, but it sounds like was very early in the course. And then several days later had an FDG PET CT. And you see uptake in the disc here at L5S1, and then also the end plates, excuse me, inferior end plate of L5 and superior end plate of S1. So that is compatible with discitis osteomyelitis at that level. So the key findings for vertebral osteomyelitis on FDG PET CT is uptake in the disc and adjacent vertebral body end plates, and then looking for any other sites of infection in these patients with bacteremia. Pitfalls, if they have a spinal neuroarthropathy or a Charcot spine, that can be a cause of a false positive, also can be a false positive on MR. And then malignancy, if it's extending into the disc space, either a primary malignancy or a metastasis can be a pitfall. And emergence of PET MRI can combine both and improve your identification as well. Other indications for F18 FDG PET CT include fever of unknown origin. It's actually excellent for fever of unknown origin because it's going to detect basically all three of the major categories that cause fever, so infectious, inflammatory, and neoplastic, and has high sensitivity of over 90%. Also a very high negative predictive value. So if you have a negative PET CT, that has a very high negative predictive value for infection. The ACR appropriateness criteria for F18 FDG PET CT in fever of unknown origin is only defined in the pediatric setting, but for pediatrics, it says may be appropriate, again, depending on clinical situation. So here's a case of a patient who had a prior aortic surgery coming in with fever and leukocytosis. And this is a fused PET CT. So here we have the PET and the CT and then fused at the level. We're right in the mediastinum. This is the top of the left ventricle here with some uptake. And then you can see they've had a prior aortic graft here with a little bit of fluid next to it. And we see intense uptake along the graft and then also in that fluid collection. And this was an infected aortic graft. We also often see sort of incidental infection or inflammation in patients coming in for oncologic imaging. We, as I mentioned, have trouble getting PET CT covered for infection as an indication, but it's not uncommon to see infection in the oncologic patients. So this was a patient who had lymphoma, prior treatment, and coming in for surveillance imaging, and was noted to have in the right lower quadrant this tubular structure. I'm only showing you one image, but it connected to the cecum. This was consistent with the appendix, and there's fat stranding around it and intense uptake on the FDG. And this was appendicitis with further clinical history. They had right lower quadrant pain and they were sent to the ER. So this was appendicitis. This was a patient with lung cancer who came in for surveillance imaging after treatment. And in the pelvis, we see this thickened loop of sigmoid colon here with inflammation and these foci of extraluminal air and intense uptake on the FDG PET portion here. And this was, again, with more clinical history, they had left lower quadrant pain. This was a perforated diverticulitis. Clearly, you'd want to be careful and make sure they had GI evaluation because a perforated colon cancer could look similar, but this ended up being diverticulitis. They were also sent to the ER. So it's quite good for infection. Another indication where it actually is covered under CMS guidelines is vasculitis. So in large vessel vasculitis with patients who have elevated inflammatory markers, there's good sensitivity and high specificity for active vasculitis. And it helps to assess extent of involvement and also monitor response to therapy. And the ACR appropriateness criteria for FDG PET CT for vasculitis is actually this is the highest rating of usually appropriate. And so here's an example from the literature of a giant cell arteritis, and you can see uptake along the wall of the aorta and the great vessels and kind of down into the abdominal aorta and iliac vessels. And this was a giant cell arteritis. So the limitations of FDG PET-CT, as I have mentioned with all of the tracers so far, is it's non-specific for infection, which can be a plus if you're trying to image fever of unknown origin. But if you specifically want to image infection, that would be a pitfall. You also see uptake in inflammation and neoplasm, as I mentioned, and it's a expensive test, and there's difficulty with reimbursement. So now I'm going to change gears a little bit and talk about emerging radiopharmaceuticals briefly. So currently the commercially available radiopharmaceuticals are relatively non-specific for differentiating infection from inflammation, as I mentioned. So you're imaging usually the immune or inflammatory response rather than the infection itself. So you're imaging the white cells, or in the bone scan, you're imaging the osteoblastic activity in response to the infection rather than the infection itself. FDG PET-CT does image metabolism of the bacteria and also the white cells. And gallium, you're imaging somewhat the siderophores of the bacteria, but also it's fairly nonspecific. So relatively nonspecific. So there's been interest in finding a more specific agent to image bacterial infections on the molecular level. And an ideal agent should be able to identify infection early, identify potentially the specific pathogen and sensitivities. Would be useful for follow-up and infection clearance. Right now, it's hard to tell whether you have just inflammation that's related to healing or ongoing infection on many of our studies. And then, as with all ideal isotopes would be easy to use, low radiation dose, low cost, et cetera. And you need it to accumulate in a high enough concentration that in bacteria that it's visible above background. So many different targets are being tested and have been tested. Some include bacterial metabolism. There are certain things about bacterial metabolism that are different from mammalian metabolism, such as folate metabolism. The bacterial dihydrokeratase synthase catalyzes the PABA, and so you can image radiolabeled PABA. Iron is used in bacterial metabolism, so there's some studies about using gallium-68 PET imaging as opposed to gallium-67 to image iron. Many antibiotics have been labeled, and antibiotics were developed to exploit the differences in bacterial metabolism and synthesis, cell wall synthesis and division and things like that compared to human cells. So it makes sense to label some of those. Bacteriophages and then parts of the immune system like cytokines and monoclonal antibodies have been labeled. This is from a recent paper out of the 3rd European Congress on Infection and Inflammation Imaging from 2020, and sort of, not a exhaustive list, but just examples of different targets. And you can see many of them are antibiotics. So they've labeled some of the cephalosporins and, targeting different parts of the cell wall synthesis, the metabolism, vitamins, things like that. So there's lots of potential targets. The difficulty with labeling antibiotics is that they're designed to kill or inhibit bacterial growth. And so it can be difficult to get high enough concentrations of your labeled antibiotic to actually be able to image them in humans and see well enough on imaging. And none of the currently sort of under investigation agents are able to differentiate between infection and inflammation with high diagnostic accuracy in humans, but definitely lots of work going on in this area. And so the challenge is, as I sort of alluded to, it needs to accumulate in the bacterial at much higher levels than the mammalian tissue in order to be detectable from background. And if you're targeting components of cell growth or multiplication, it's not going to be as sensitive for your slow growing organisms. And there's, different, if there's hypoxia or things like that, there's variations in growth and the local environment. So that can be a challenge. And then many bacteria have developed drug resistance. So if you're targeting, an antibiotic, if you're labeling an antibiotic, it may not identify bacteria if it has a drug resistance. So it's definitely, there are many challenges, but it's an area of active research. So hopefully more will come out of that. So in summary, there are still specific indications where nuclear medicine study may be very helpful in problem solving. We covered a few of those. So fever of unknown origin, infected hardware, osteomyelitis, or if there's contraindications to MR, can be very helpful for problem solving. And then there's potential for more specific molecular imaging of infection on the horizon. So hopeful for that as well. I think it's a dynamic field and it's exciting time. So these are my references, which I'm happy to send out if people want more information. And thank you. I'm happy to take questions.
Thanks so much, Dr. Connolly. That was a wonderful talk about infection and some of the cases you see there at Mount Auburn. I think we will open it up for a few minutes. If anybody has any questions, feel free to type them in the Q&A. It's just a button on the bottom there. There were a few comments from Dr. Catherine Morton. I'll read them. You feel free to weigh in if you like. So in chronic non-pyogenic inflammation, such as with Charcot, mononuclear cells infiltrate the region, and then monocytes differentiate into macrophages, which accumulate technetium-99 sulfur colloid. So because the cells labeled with indium or with technetium-99 HMPAO include some mononuclear cells, indium may accumulate in regions of chronic inflammation without infection. So she's saying if there's pyogenic infection, the neutrophils replace mononuclear cells, and that happens quickly. So that's why you compare the indium to the sulfur colloid scan. You can differentiate between infected and non-infected Charcot or chronic inflammation.
Perfect. Thank you for
yeah,
that's great.
And then she had one other question or a comment, I should say, about kind of the CMS and the use of reimbursement for PET. Just saying, it looks like there is reimbursement options if it's other than a hip prostheses, but that it's kind of up to the local Medicare administrative contractor. It sounds like an important person to know. So having some communication with them may help in improving reimbursement for some of those cases. Great, and other questions that others may have? I had a burning MSK question about using tagged white blood cell scans, especially in cases with hardware, right? So we do some metal suppression MRI, but we find for cases of infection, it's not great. And it ends up being sometimes the first line imaging. Is that opposite at your institution where the tagged white blood cell scan is kind of the first line imaging and MRI kind of falls secondary?
Typically it's MR first if they can get an MR, but if it's, it's still a clinical conundrum after the MR, or if they for some reason can't get an MR, then we will sometimes start with the tagged white blood cell scan, but typically it is MR first and trying to do some of those metal suppression techniques first.
Great, thank you. Looks like Dr. Anzai also has a question.
There.
Hi, sorry, I'm in a reading room. Thank you so much for the lecture. I have a question. Nuclear medicine imaging used to kind of lack anatomical information, but because of the SPECT CT that are available now, you are able to provide precise location of radio trace activity. So how do you think that SPECT CT in the setting of infection information in nuclear medicine? The second question is the timing of FDG for infection information. Obviously, cancer FDG uptake and cancer tend to increase as time goes by, but infection information, the timing is different. So how do you use that difference in the kinetic information for imaging of infection information using FDG? Perhaps you can shorten the scan time, or I just wanted to know what's the most up-to-date information about timing and also use of SPECT CT.
Yeah, so I think SPECT CT has really helped with localization and specificity of the scans. You know, I showed the case of the Crohn's disease, and it would have been very non-specific on just the planar imaging, but having the correlate with the SPECT CT and you know, seeing that the correlated with that presacral abscess and things like that, I think definitely improves your specificity on those SPECT CTs and really localizes better. In terms of the timing of the FDG, I honestly am not sure. I don't have an answer for that, whether people are doing shorter protocols. I think, yeah, I'm not sure, honestly. So it's unfortunately, we have not had much luck in getting it reimbursed here. So we're not using it as much clinically. But I think it's exciting. And I know in Europe, they use it fairly extensively because they don't have as many issues with reimbursement. So I think it's definitely a good option for answering many of the questions we have. And so there's more and more research coming out, but I don't know off the top of my head about timing. So sorry, I can't answer that for you.
So there's a question in the QA from Dr. Richard Brown. He says that they used it at Michigan, but mostly inpatients. So it was not reimbursed at Michigan either. So it seems to be a common problem.
Yeah.
Great. Any other Q&A from our participants here? All right, well, we may wrap it up a few minutes early. Lots of commentary about what a wonderful talk it was. It was a pleasure having you, Dr. Connolly. We really appreciate your expertise in the field. Thanks for visiting the University of Utah, and we will sign off for now.
Thank you so much. I really appreciate you having me, and I'm so glad I could be here. So take care.
Thank you.